Hi, my name is Rebecca Lucero, and today's lecture is going to be on self-harm. We will be discussing self-harm as a process addiction, and we'll also be talking about assumptions that people make, misconceptions, what self-harm is, and how it affects the family. First, I'd like you to think about your assumptions about self-harm. Often when people think about self-harm, they think about the act of cutting. So what are your assumptions about cutting? What are your assumptions of why someone would cut? And how do those assumptions impact your openness to hearing stories about cutting? So first I want to talk about what is self-harm. Self-injurious behavior is defined as deliberate, repetitive, impulsive, non-lethal harming of one's body. These authors define it as the deliberate, direct destruction of or alteration of body tissue without conscious suicidal intent. The intentional harming of one's body in order to reduce emotional pain and cope with overwhelming emotions. So I want you to think about some different methods of self-harm, and some of these you might be familiar with, and some of them you might not. So here we have listed cutting, right? That's the most common one you've probably heard of. Burning, hitting oneself or objects, pulling one's hair out, scratching oneself, picking scabs or interfering with wound healing, breaking bones, infecting oneself, inserting objects in body openings. So all of these can be different forms of self-harm. The risks of self-harm include physical disfigurement, social isolation, hospitalization, and even death. Obviously, depending on the severity of the injury, it could cause death. Also, sometimes people who self-injure are not aware of the possible infection that could result in self-harm. So often people might be using unclean blades to cut, and that could cause an infection that could lead to death. Let's talk about comorbidity because often people who self-injure also experience diagnoses of depression, anxiety, and maybe even substance abuse disorders. So right now, self-harm is not considered to be a diagnosis. So we do have a diagnostic criteria that has been proposed, though, and that would include the following: a preoccupation with harming oneself physically, recurrent failure to resist impulses to harm oneself physically, resulting in the destruction or alteration of one's body tissue, a sense of tension present immediately before the act is committed, relaxation, gratification, pleasant feelings, and or numbness experienced with the physical pain, self-injury that is not associated with conscious suicidal intent or self-mental retardation. We're going to discuss the incidence and onset of self-harm. So in the U.S. population, self-injurers represent about 4% of adults, 15% among teens, and maybe as high as 17 to 35% of people among college students. So as you can see, it is more common when people are younger to be engaging in self-injurious behavior. It's more common in females than males, and the typical onset is at puberty. The majority of people who self-injure are going to be women between the ages of 13 and 30, but there are people who self-harm from every age, gender, and economic group, right? This is not reduced just to one group, although it may be more common in that group, but this can happen to really anybody. The behavior lasts for 5 to 10 years typically, and it could last longer if they do not receive proper treatment. So a little bit about the background or why this occurs. Nearly 50% of self-injurers report physical and or sexual abuse during his or her childhood. Also, the experience of self-harm allows the person to dissociate. Now, if some of you are familiar with trauma, often people who are trauma victims will dissociate. And what that means is that when something is happening, they're able to go somewhere else in their mind. And actually, the act of self-harming allows that person to experience that, right? Where they are no longer present in the moment. And that is something that's very typical for somebody experiencing trauma, that they would want to escape from the present moment, and self-harm allows them to do that. So that makes sense that anybody who suffered trauma or abuse, being able to experience that dissociation again would be desirable. As high as 90% of self-injurers report that they were discouraged from expressing emotions, particularly anger and sadness. Self-harm plays a role in reducing emotional pain and serves as a coping mechanism. It transforms emotional pain into physical pain. It can also help the person to feel alive. Feeling pain can be reassuring when somebody is typically feeling numb. So this allows them to feel something. It is also a way for them to express anger towards themselves or to punish themselves. It also allows them to express something they can't say in words. we're also going to discuss a little bit more of why people self-injure. So individuals report engaging in self-harm to regulate emotions. They also report engaging in the behavior to avoid killing themselves, right? So this is different. A lot of times people think self-harm is with the intention to kill themselves, and often maybe what you consider the opposite, because it is to avoid killing themselves. Self-harm behaviors are engaged as a coping mechanism. It helps them gain relief or escape from difficult emotions. There's also a four-factor explanatory model. And in this model, we explore these different reinforcements. There's the intrapersonal negative reinforcement, which reduces negative emotions, right? So that when the person engages in this behavior, their anxiety and their anger go down. There's the intrapersonal positive reinforcement, right? Where we're seeing within the person, they feel relief from feeling numb or empty. Then there's the interpersonal, right? Where we're looking between people, where there's a positive reinforcement where they're gaining attention or emotional support from peers who are noticing the behaviors. There's also the interpersonal negative reinforcement or reduction in victimization. Some misconceptions about self-harm. I want to discuss those because there are some. Self-harm behavior is not suicidal behavior. Suicidal individuals want to die to end the pain. Individuals who self-harm want to live, but they feel the only way they can remain in control is to self-injure. When I get clients and people say that maybe their daughters tried to commit suicide, or they're worried about the daughter committing suicide because she self-injures, any kind of situation like that, I ask a lot of questions about what the injury looks like, because sometimes people think that just because someone cuts themselves, especially on the wrist, that they were trying to kill themselves. And often, if you have enough knowledge about the way that people injure, you would be able to note the difference between an intent to kill themselves or an intent to relieve pain or regulate emotions. And so often as a clinician, it's very important to know the difference between these things. Although sometimes self-injury can indicate depression, which could be also something that would lead to suicide. So it's not that the two are completely unconnected, but self-harm is not always a predecessor to suicidal behavior. Also, in some cases, self-harmers cut in visible places as a source of attention or as a cry of help. However, most of the time, self-harm is something individuals want to keep hidden. A lot of people assume that people self-harm or, might cut their wrists as a way to gain attention, and that's not always true. Sometimes they really do want to keep it hidden, and it is not a cry for attention. So some of the research is pretty inconsistent on suicide and self-harm. Some research has shown that self-harm is a risk factor for suicide. And what this means is that it has been present in individuals who have committed suicide 40% of the time. So 40% of suicides are with people who have had a history of self-harm. So there is some correlation there, but we don't really know that there's causation. In another study, only a small percentage of people who self-harm have been found to commit suicide in later years. We have another study that talks about 28 to 41% of individuals who have self-harmed have reported past suicidal ideation. And then we have another study that says 55 to 85% have a history of at least one attempt of suicide. We also have another study that says less than 1% report wanting to die was the precipitating reason for self-injury, right? So here we're seeing that most people are not self-injuring with the intent to die. We get a lot of mixed messages in the research, but we do know that they could be related. So it's really important to not ignore the risk of suicidality among those who self-harm. So it's very important to note this and assess for suicidality if somebody was to have a client who self-harms. So there may be some correlation, but not necessarily. We can't assume that everyone that self-harms is doing it with the intention to commit suicide, or that they even have thoughts of suicide. Right now, there is no diagnosis for self-harm, so often it falls under the diagnosis of obsessive compulsive behavior. And the way they explain this is that the brain begins to connect the false sense of relief from the bad feelings to the act of cutting or self-harm. Then the brain craves the relief the next time the tension builds. This behavior reduces physiological and psychological tension rapidly. So this process explains why self-harm becomes kind of this repetitive behavior that we're finding in certain persons. So let's talk about, is self-harm an addiction? Because some people view it as a process addiction and some other people might disagree, and that's why it's currently being diagnosed as an obsessive compulsive behavior. Sandman and Hetrick identified an increase in opioid production after a self-harm episode. So we're seeing some changes in the brain when we see that someone is self-harming. With the need to escape difficult emotions being coupled with this biochemical process, there's a potential for dependency to develop. Like we've talked about before in the process of addiction, we'll see that there's similar processes going on in the brain when someone engages in the self-harming behaviors. The researchers draw the comparison of self-harm with the physiology of heroin addiction, right? So that's what they're noting is kind of a similar process in the brain. It's important to note that research on this topic is scarce. So I wanted to go over the self-harm cycle with the process addiction. So you can see here that the person might feel some sort of shame or bad feeling, and that will result in feeling triggered, right? They will start to feel uncomfortable, the tension, the anxiety. They will need a coping mechanism. And as they don't engage in a coping mechanism or don't have one or don't have skills, the tension and the emotion will continue to build, which will drive them to self-harm, right? That's the way that they're coping. And they will experience temporary relief from the pain, but then following that, they might feel shame about the cutting behavior, or the shame from whatever else they might be experiencing in their life will also begin the cycle again. So another article that kind of discusses some things about cutting or self-injury, it's called Cutting to Live, a Phenomenology. It's by Brown and Kimball. Three themes emerged in this study, and so they looked at self-harm as misunderstood, the role of self-harm, and advice to professionals. So when we look at the first theme, self-harm is misunderstood, the authors highlight that self-harm is not suicide. They discuss that self-harm is an addiction. They also explain that individuals who self-harm have been traumatized, and also they talk about help that is not helpful. In the next theme that emerged, the role of self-harm, they talk about how self-harm provides a release. They talk about the self-injurer's need to be punished. They also talk about the physical pain versus emotional pain, and they also talk about how self-harm provides a sense of control. And then in the last part of their study, they discuss how it's some advice for professionals. And they talk about how self-injurers discuss that they are not suicidal, and how they don't want people to be judging them, and also the importance of getting educated. So let's talk about some families in the development of NSSI. And NSSI is just short for non-suicidal self-injury. So research indicates that those who self-harm may grow up in families with divorce, high conflict, abuse, neglect, addiction, and other psychopathology. Another study shows that the fuel that drives self-injury is the way family members relate to each other. Adolescents may engage in self-harm because they have authoritarian parents or parents who are passive and provide little attention and emotional support. Also, we find that in adolescents that are self-harming, we'll find parents that have parenting styles that do not allow for open expression of emotions and nurturance. Also, we'll see instability in the family, right? Maybe there's moving, illness, death, abuse that might be physical, sexual, it might be emotional, it could be neglect. There might be rigid values that are applied hypocritically or inconsistently. There will be structural breakdowns, maybe demands on the child to take on adult responsibilities. So as you see here, if we look at all these are things that we have talked about this whole semester, relating to, just what we see in the addict family. So it makes sense that we would maybe see self-harm as a process addiction because it is a behavior or set of behaviors that is emerging out of a similar type of family. And also we see that it has some very common similarities in terms of what's physiologically going on in the body as far as the addiction process. So we see it a similar individual cycle in terms of physiologically what's going on in the body and also what's happening in the family. Family relationships may exacerbate or offer protection from the consequences of traumatic childhood experiences, and that caregiving relationships may influence the etiology of self-harm. Also, adolescent self-criticism paired with low levels of parental criticism was not associated with self-harm, but high adolescent self-criticism and high parental self-criticism associated with daughters using self-injury. So we can see that when both the child and the parents are highly critical of the child, we'll see self-injury. But that will not be present if the parents are not critical. Higher levels of family conflict are common in self-injury, as well as lower levels of family cohesion, independence, organization, and control. We also find that studies indicate that family dynamics influence development, maintenance, and prevention of self-injury behaviors. So this is similar to the things that we've discussed earlier in the semester concerning addiction, that the family contributes to not only the development, but also to the maintenance and prevention of any type of addiction process. So some more on self-harm in the family. Each family member may react differently to the engagement of self-harm behaviors. And they may be angry, they may feel guilt, there might be sadness, there might be shame. All of these are, emotions that are commonly present in individuals as they learn about their loved one's self-harming behaviors. Family members might struggle to understand the behavior and will fear that the individual is intending to commit suicide. Family members should also be encouraged to share their experience of the self-harm behaviors to help the individual to see that their behaviors have an impact on the whole system. So in a qualitative study, they looked at the impact of self-harm by young people on parents and the family. So here we're kind of looking at, how the self-injury is impacting the whole family. So we see under immediate impact, there might be different means of discovery, and what that means is that individuals might find out in different ways about the self-injury. But no matter what the means of discovering it were, it was still very distressful when they discovered. The initial reactions that people usually experience are shock, fear, disbelief, anger, feeling frustrated, also feeling really helpless. When we look at the ongoing impact of parents' emotional state and mental health, they can experience a lot of emotional difficulty, a lot of maybe crying, anxiety, stress, guilt, shame, embarrassment, depression. Also, we might see that there will be stress created. There might be some physical symptoms created by the stress, maybe panic attacks, upset stomach, anxiety symptoms. When we look at the impact on partners, we can see that there was a strain on the marital relationship. Often parents might feel like their life is on hold until the child is better. We also might see they might be hiding information from one another about the child. When we look at the impact on siblings, siblings also experience difficult emotions. They might feel resentful or frustrated or worried about their sibling. Often they would provide support to the sibling that's engaging in the behavior. Also, a fear of stigma. They might avoid talking about it to other people. They might not want other people to know that their sibling is engaging in this behavior. As far as the impact on the wider family, we learned that it increased existing issues between the extended family. Sometimes it brought extended family closer. Sometimes there was a fear about overreacting or blaming or judgment. They also looked at social isolation and social support. Sometimes people would try to keep the child's problem private, and that would cut them off socially. And other times people noted that friends were very supportive. As far as impact on work and finances, the study saw that self-harm behaviors made parents reduce work hours or stop their full-time job. Sometimes they would take paid or unpaid leave. They might be taking a career break. And often they might have had to increase spending on healthcare services for the child as a result of injuries that were happening due to the self-harm. Also, the parents' conception of the future, sometimes people felt optimistic, sometimes people felt really fearful to think beyond what was going on right now. And often they might feel fear of the child's ability to cope in the future as an adult. So when we look at evaluation and treatment, I just want to note a few things. If someone displays signs of cutting, a mental health professional should be consulted. Outpatient and inpatient treatments are available. It can include a combination of cognitive behavioral therapy, talk therapy, relational therapy, right? Maybe some family therapy, and also medication. Another thing to note is that aftercare planning is vital to the success of treatment. And we've talked about this early in the semester, how it's really important that when an individual is struggling with an addiction, that they not just go to treatment and then come back into the same environment and do the same things, right? It will be important that things are changing and helping them to enter recovery, not just as an individual, but as a whole family. I hope this PowerPoint provided you some new information that helped you to better understand what self-harm is and what it isn't, and what that looks like for a family who is dealing with someone who might be dealing with the process addiction of self-injury.